I try to imagine a fellow smarter than myself, and then I try to think, what would he do?
Charge up your axons, ready your receptors, and shift your lobes into upper beta phase. You are listening to Smart Drug Smarts, the podcast dedicated to helping you optimize your brain with the latest breakthroughs in neuroscience, nootropics, and psychopharmacology.
Hello and welcome to Smart Drug Smarts. I am your host, Jesse Lawler, here with the 23rd episode of this podcast, where we like to talk about everything and anything that we can think of that is related to the improvement of your own brain, specifically with artificial means like chemicals and crazy, wacky appliances. Today is going to be a crazy, wacky appliance episode, and I think this might actually be our first one no, that's not true. That is not our first one. So today's episode, we're going to be talking about something we made reference to a few episodes ago, but it took me a while to find a bona fide expert for, but I did. This is the technology known as tDCS, which is the affectionate name for it, but a longer way of saying it is Transcranial Direct Current Stimulation, which, if you remember Back to the Future, the movie series from the 80s, and there was Dr. Emmett Brown, played by Christopher Lloyd, memorable performance, and when we first meet that character, he's wearing this wacky thing on his head. It's like a polyhedron, 20-sided Dungeons and Dragons dice-looking thing. Presumably that's either reading his brain waves or applying current to his brain to give him extra brain waves so he can read people's minds, something like that. That would be sort of a wacky sci-fi take on this technology, which is the idea for it has been around for a while, that you might be able to affect what's going on inside people's skulls by applying non-invasive electrical or magnetic currents from outside the scalp. There's a lot of research going on in that area now, and some products that are even coming to market for people like video gamers who really want to overclock their brain, I guess would be the way of thinking about it. But we're going to be talking with Dr. Felipe Fregni, who is the director of the Spaulding Center of Neuromodulation at the Harvard Medical School, which is a pretty awesome title, and he's probably one of the most well-informed guys around on this particular field. But before we get to that, we'll of course have the This Week in Neuroscience, and if you stick around until the very end of this episode, I'm going to tell you something which really has absolutely nothing to do with brains in particular, but the only clue that I'm going to give is that it deals with the fine nation of Korea and the people there, and an interesting, let's just say habitual way of thinking that they have. Anyway, hang around to find out what that is, but right now, This Week in Neuroscience.
Smart Drug Smarts, This Week in Neuroscience.
So one of the things that I've discovered while doing Smart Drug Smarts as a podcast and reading more scientific journals than I previously ever had is that most of these have really kind of boring article names, and some of the pithy stuff that you're used to if you're reading Newsweek, for example, is it's a lot more interesting to read. So take this one, for example. Transdermal delivery of cannabidiol attenuates binge alcohol-induced neurodegeneration in a rodent model of an alcohol use disorder. Sounds kind of boring, but what they're really kind of studying here, like here's the college student translation. If you're going out binge drinking, then possibly rubbing some stuff from marijuana on your skin could make your brain not as brain damaged the next morning. And that seems to be a generally true statement based on what they found in this study. There's something called cannabidiol, which is inside marijuana. It gives marijuana a scientific name, cannabis. And cannabidiol is a very strong antioxidant, and antioxidants are generally neuroprotective, keeping you from being able to damage your brain as much from heavy oxidation. Oxidation is one of the things that happens when you do binge drinking, among other things. What they were doing is essentially getting rats really, really, really drunk and putting an ointment on them that contains significant levels of cannabidiol, and they found that the cannabidiol does in fact protect the rats' brains from the brain damage that they would be getting from the alcohol poisoning. None of this is to say that just if you're going to go out drinking for the weekend, you should probably smoke a bunch of pot on top of that. I would never really recommend either one of those things, but it is an interesting article, and it's interesting that this kind of research is going on at our fine academic institutions.
Smart Drug Smarts.
All right, so our guest today is the director of the Spaulding Center of Neuromodulation, Dr. Felipe Fregni. As mentioned, he's a PhD and MD, a couple other acronyms that I didn't even recognize, and pretty educated dude, as you might imagine. He's got a list of published papers as long as your arm, but let me give you just a couple of titles here. Motor cortex-induced plasticity by non-invasive brain stimulation, a comparison between transcranial direct current stimulation and transcranial magnetic stimulation. Or how about this? The effect of transcranial direct current stimulation combined with gait and mobility training on functionality in children with cerebral palsy. I mean, basically, this is the focus of his research, what we're talking about here. So we have come to the right spot if you want to learn about tDCS. Let's just dive right in.
Smart Drug Smarts.
Yeah, I guess sort of to start off with, I would just love it if you could give me an overview of what transcranial direct current stimulation is and how this differs from some of the different techniques that people have been using for, I guess, almost the past 200 years. People have been playing with applying currents or voltages to the brain and seeing what results from that. But it seems like there's a lot of new interest in this territory.
So transcranial direct current stimulation is an old technique of brain stimulation, non-invasive brain stimulation. Although it is an old technique of brain stimulation, now it's being used very differently than before. So before, the parameters of stimulation, how it was used was very different than now. And the way that we use now, we learned from recent studies. We learned the optimal parameters of stimulation. We learned where to place the electrodes, and we learned how to make it effective. So that's a difference of transcranial direct stimulation now compared to before. And compared to other techniques of brain stimulation, non-invasive brain stimulation, tDCS has one main difference. We deliver the current as continuous current, meaning the current has one direction only. Usually, when you deliver brain stimulation, it's delivered through pulses. But here is different because we delivered current continuously. So
it's like a battery versus an alternating current that you would have in an electric socket.
Exactly. That is the main difference. And and we know that by delivering that continuously, it induces changes that become cumulative. And that's the interesting part of tDCS, because even if you deliver a small amount of current, over time, the changes can build up, and then you can see significant changes if you wait. If you apply enough current, a duration that we know it's effective. So that's the main characteristic of transcranial direct current stimulation.
So tell me, in sort of a what would be considered an optimal session in the way that this is being done today, how much current is applied to a person, and how long is the current applied for? How long does the session last in order to actually have measurable benefits to their cognition?
Sure. So usually, and that's something that we are learning with recent studies, and that's one actually question that we've been doing all the time. So what are the optimal parameters of stimulation? But one thing that we know is that at least if you apply currents or tDCS for at least 20 minutes or even 10 minutes, it is enough to induce significant changes in cortical excitability and significant behavioral changes. So we know that, for instance, a standard session of tDCS consists of placing the electrodes on your head, finding the optimal position, and then delivering 1 to 2 milliamps for at least 10 minutes. If you do that, we know that changes cortical excitability significantly. You can either increase or decrease cortical excitability according to the polarity of stimulation, and that is also associated with behavioral changes. In a way, for instance, you were applying stimulation over the motor cortex. We know that induces changes in motor behavior, and if you're doing other areas such as cognitive areas, it can induce other changes. For instance, working memory, mood, and it depends on the area that we are looking.
Interesting. And now, as I was reading about this, I saw that sometimes they use anodal versus cathodal, which, as I understand it, means basically a positive current being applied or a negative current being applied, or I guess sort of sucking positive ions out of somebody's brain. And so you can either excite a certain area of the brain or sort of do the opposite of make it less likely that neurons are going to fire in a particular area, and that it's actually sort of de-exciting certain parts of the brain is useful in cases like, if I understood this correctly, if somebody has a problem with depression, and sometimes that's a problem with a part of the brain being hyperactive because it's worrying too much. So can you talk about both sides of that coin, exciting certain parts of the brain versus making certain parts of the brain less likely to be active?
So yes, you can use tDCS exactly to increase excitability in certain areas of the brain or decrease excitability in certain areas of the brain. We know the mechanisms are are likely related to changed local ionic concentrations. When you create this constant gradient of voltage, there is a sort of a temporary displacement of ionic, or less concentration of ions, in which under the anodal electrode, you see a tendency for a depolarization, meaning it's easier to generate action potentials. And then in the area of cathodal, it actually causes a hyperpolarization, meaning it's more difficult to generate action potentials. So that's what we see with either anodal or cathodal stimulation. And you can use these properties to induce different behavioral changes. And I think that's an interesting part of tDCS as well. Of course, you do have it with some other techniques of brain stimulation, but tDCS has these very nice opposite effects that you can use to modulate different areas of the brain differently. So you want to induce a depolarization in one area of the brain, for instance, in depression, in order to increase activity there. And that's how it's used. We know that in depression, there is this imbalance between left and right hemisphere. We wanted to increase excitability in the left hemisphere and decrease excitability in the right hemisphere. So then you can use anodal stimulation over the left prefrontal cortex, and you can use cathodal stimulation over the right dorsolateral prefrontal cortex in order to decrease activity over the sort of right hemisphere. So, and I think that's the interesting part of tDCS, using this dual effect simultaneously. For instance, in stroke subjects, we can also use that to increase excitability over the lesion hemisphere, over the lesion motor cortex, and decrease excitability over the unaffected motor cortex. We know that unaffected motor cortex tends to increase excitability over time in stroke subjects, and that actually may worsen the motor function. So with tDCS, you can reestablish this normal, or this not normal, this abnormal imbalance that you have between left and right hemisphere, and then correct that using one technique that you can do, so this dual modulation. But on the other hand, you can also use, if you want to use one electrode only in order to just increase, it's possible as well. You can place the electrodes in an extracephalic position. You can use a larger electrode. So it's an interesting technique that is flexible as well, and you can adapt and you can design according to whatever dysfunction in excitability, in cortical excitability you have associated with any condition. So I think that's also one advantage of brain stimulation in general, but particularly in tDCS, is that the treatments may be better designed for that condition, and you have much more control what are the changes you are affecting.
Yeah, it seems like you've got some flexibility there. How detailed, I mean, obviously, the brain operates on such a nano scale in many cases, since the current is being applied on the outside of the scalp and is having to, cross through skin and bone and all this, tissue in order to actually reach, neurons. Do you feel like, well, obviously you're not going to have the same level of control as if you're actually putting a wire into a brain, but do you still feel like there's a, sufficient level of control of what areas of the brain are being stimulated doing an external treatment like this, a non-invasive treatment?
Yeah, that's a great question. And the answer is no. Although in my previous comments, I was sort of comparing with pharmacological treatments in which you have more control, but I agree with you. You don't have it as much control that you would want. Although it's also debatable how much focal you need to be and how much you would add in terms of the clinical effects. We know that it's important to be focal. We know that it's the brain activity. It does have this sort of paradoxical facilitation or inhibition in other areas of the brain. We know you want to be relatively focal, but tDCS is not as focal as you would want to. And even thinking in deep brain stimulation, that's of course much more focal, it's not even as focal as to affect one specific neural circuit. For this exactly, we would need to do nanotechnology. We need to be really, really small, and then of course really invasive. And the other point is that even if we have the technology, we cannot identify with that precision the network that is dysfunctional. All our techniques for assessments, they're also very rough as well. So, and that's an interesting challenge, because even if you develop a technology that can be more focal, then you don't know where to go.
Right, you need to find out where to focus. Oh, so here's a question that I guess I want to tie back to from earlier. So you said that within about 10 minutes you can start to see results from the application of current. How long after sort of the cessation of current do the effects that you see continue to last in people? How is this something that has a real long lag time before the brain sort of drops back to its baseline behaviors? What do you see in there?
Sure, that's also one a good question, and actually in terms of duration of treatment, or let's put it in a different way, duration after effects, that's one of the reasons researchers and the community got so interested in tDCS, because it showed that even 10 minutes of tDCS, you can have effects lasting up to an hour and a half. So, which is very impressive. So when this paper was published by the group in Germany, Walter Paulus and Michael Nitsch, and that's actually when I got interested, because you have a very simple technique. You need a battery, a 9-volt battery operated device. Just by applying 10 minutes of stimulation, you can induce changes that can last up to 1 hour and a half, which is very impressive, because even the changes, if you see the magnitude of the changes, you were saying something about 50% increase in the baseline levels of cortical excitability. So a very simple technique can induce those changes. That's, of course, you can see a clinical application for that.
Yeah. Now that sounds huge to me. A 50% increase in the baseline level of cortical excitability. How does that transfer to the macro scale of somebody actually, like if it's motor functions in a stroke patient, for example, somebody's reaction speed in catching a baseball or taking their hand off a burning, stove burner or something like that? Does a 50% change in cortical excitability lead to sort of, a 50% change at the actual level of sort of the organism?
Sure. That's also, again, a very nice, very good question. And that's also one thing that it's very important to be understood. And then we're now more and more understanding, because all these studies, they measure neurophysiological parameters or the surrogate outcomes, and they do not translate directly to clinical effects, and that we see it. And that's also one important thing when looking at these results, because this 50% increase in cortical excitability, it's not translated in 50% increase in motor function. And the main reason is that when you're doing that, so it leaves your cortex ready, or it increases the chance of neuronal firing. So, and then by training is how you're going to increase your performance. And that's the difference of tDCS. tDCS does not induce activity per se, but just increase the likelihood that activity will occur. But you still need to have a presynaptic input in order to generate this activity. So what we see, and you still need to generate this activity in order to improve performance, to decrease reaction time. So sometimes you can see a immediate decrease in reaction time, but it's not as much as the increase in excitability. So you are leaving your cortex in a better state in order to process presynaptic input. But you still need that, and that it still needs to be processed in order to result in behavioral changes. And as more complex you were looking at the behavioral assessment, then less translation you have it, because the system then it also depends on the other networks. So that's also one thing that we've been seeing. It needs to be coupled, and also it's associated with the plastic changes as well. So as more as you do it, and then that's also the second important point, is that it's not just one session, it's several sessions over time in order to induce significant changes, in order to induce plastic changes that will last longer. And then you start having changes in the magnitude of the effects. Because one thing that's also very interesting, sometimes you don't even see a change in the magnitude of the effects, for instance, motor function. But what you see it is that the learning of a new motor task, it lasts longer than learning the task without tDCS.
Interesting. So that would seem to imply that there's some long-term sort of structural changes, maybe new axons being formed or something like that, rather than just making the connections that are already there more likely to fire. Is that correct?
Yes, that's a very important important concept. Yeah. So the initial immediate effects is just sort of make the neurons in a state that the likelihood of neuronal firing is higher. However, the changes, and especially to see long-lasting changes and to see changes in consolidation or changes in performance, it depends on synaptic strengthening. And that's the difference between sort of looking at the immediate changes. It may decrease reaction time, may increase your attention levels, but then with that, you'll be able to activate the network in a sort of an easier way. And that will create synaptic changes, will increase synaptic strengthening that will lead to changes in performance. So I think that's a very important point. So the immediate changes are different than the long-term changes. And of course, in terms of rehabilitation, change in cognition, change in motor function, change in sensory processing, you're interested in long-term changes.
Right. So if you have a stroke patient that is being rehabilitated with the use of tDCS, how frequently would they go in for their sessions? How long would these sessions last? Is it something, since you mentioned that a power source as small as a 9-volt battery can really affect these changes? Is this something where it's all happening within a hospital environment, or are they literally wearing a little electrical current helmet home with them and doing this on their own time? Like, what's sort of the state of the technology here?
In terms of thinking on practical aspects of tDCS use or even research with tDCS in stroke. So if you have a patient coming, for instance, for stroke, if you have a patient coming with stroke for treatment, let's say motor recovery, you were applying tDCS over the motor cortex to improve motor function. The patient will come daily for sessions, and that's an important thing that we see as well. So you need consecutive sessions in order to induce behavioral changes, and especially changes that would be clinically significant. And for each session, you are thinking at least 20 minutes of stimulation, 10 to 20 minutes of stimulation, at least 5 to 10 days. And usually when we do that, we do combined with physical therapy. So that's the protocol, for instance, for stroke that we usually do in our studies. And the whole setup, if you think coming in, receiving stimulation and leaving, it would be about an hour session for doing everything. And that's an important thing as well, whether in the future tDCS will be a technique that could be used at home. And that's what we wanted to test as well. We have a protocol, a research protocol, in which we're looking whether you can use this technique at home in the future.
We're already starting to see people that are entering the market. It seems like it's in the video game market right now. People that are taking their video games very, very seriously, and people are selling products that are claiming to be using, I'm not sure if it's quite clinical level tDCS, but are trying to use the same technology for, not for something like stroke recovery or for traditional medical purposes, but just to sort of overclock their own brain so they can be super competitors with their video game friends. What's your take on this sort of, at-home use recreationally?
Sure. Yeah, that's one thing that and myself as a researcher, we don't like that, because they're taking some of the results that studies using cognitive assessments under very specific conditions, that these studies show some changes in cognitive skills or performance, and sometimes very small changes. So they're translating that to video game, and they also translating that using a method of simulation that has not been tested before. I'm not saying that it's not going to work, but there are many issues on that use that's complicated. And again, especially I haven't seen the data. It might be there, and might be my knowledge that I haven't seen that, but at least it's not evident whether this strategy that they wanted to use, one, it works in terms of the method of simulation. Two, it's safe as well for continuous use, and then three, sort of whether the effects would be beneficial at the end. So that's the point that's a bit complicated for us in the field to analyze. Again, it might be something that may be effective, may be safe, and may be very interesting to use, but it's important to test these in appropriate placebo-controlled studies to see long-term safety, to see whether this is inducing positive effects and not detrimental effects. So that's for us is complicated. So even now, for instance, we have a study looking at home use tDCS, and it's a very specially designed study in which we do constant assessments. We look at how it's being used. We need to test that before we make conclusions and start using commercially.
Yeah, it's always a little dangerous when the marketing folks go running off with a new piece of science, and there's always a lot of hoopla that may or may not be justified. But they're trying to take long scientific papers with a whole lot of caveats and things that we admit we don't know yet, and turn it into a 30-second commercial jingle. So some information gets lost along the way.
Exactly, and then the jump for this sort of the studies to the clinical use may be too big, and then that's a problem.
You mentioned safety. One of the things that I've read consistently is that one of the things people like about tDCS right now is that it really has been shown to be very safe for human use. Do you want to riff on that a little versus some of the other forms of applying electricity to the brain that people have been experimenting with for the past 150 years?
Sure, and that's that's also another very important issue, and that's another characteristic of tDCS that is attractive. It's safety, different than TMS, another non-invasive brain stimulation technique that has been used frequently. tDCS, for instance, has not been shown to induce seizures, and even in epileptic patients, some studies in epileptic patients in which a nodal stimulation has been applied in areas that are associated with epileptic spikes. You don't see an increase in spikes. You don't see any increase in epileptic activity. So also shows and confirms the tDCS has been shown to be a safe technique. Using the parameters that we are using, we know as well that does not induce histological lesion. There are some animal studies showing that. But on the other hand, it also needs to be, whoever is using and testing, they need to follow the parameters of stimulation that have been tested and have been published. Because if you start increasing the intensity, for instance, or even the current density, you may then start inducing lesions, and then may start getting unsafe and dangerous. So, and that's one thing that's a bit tricky as well with tDCS, because it's simple, easily available, different than TMS. That's a bit more complicated to have.
CMS is cranial magnetic
stimulation.
Yeah.
Yes. So it's easy. The information is out there. You even see in YouTube some people doing home-based tDCS and or with their devices then develop themselves. And if they start using higher intensities or for longer period of duration, that then you may start seeing some effects that may be dangerous and may be detrimental. And another important thing as well that we don't have an answer right now is that whenever we induce plasticity in an area of the brain, there's always the risk that you may be inducing detrimental plasticity or maladaptive plasticity in other areas of the brain. If you want to train one behavior or you want to increase connectivity in one network, it may have a negative impact in other networks. So that's also an important consideration should be made. There's not much evidence. It may be because for lacking of looking for that's the case. But we know that in terms of other studies and the behavior studies, that's one issue.
Yeah, I guess that seems like a really important point to make. And my gut instinct is that, for somebody that suffered a stroke and that there's clearly something that has gone wrong with a certain part of their brain that maybe needs a little boost, something like this seems like it could be really beneficial for sort of a healthy person whose brain is, theoretically operating as it it should be. I wonder if turning up the voltage on one section of the brain, might not have a sort of a corollary negative effect. Like, the brain, hopefully in a healthy state, is a fairly well-balanced, well-oiled machine thanks to, millions and billions of years of evolution. So, I question whether for a healthy person, the application of a current to one area isn't going to have sort of a corresponding downside somewhere else.
Yes, again, exactly, a very important issue. And that's also one point that needs to be considered, whether in healthy subjects in which you have, at least theoretically, you have your systems, they are pretty much balanced. If you induce an imbalance, whether that will have a detrimental effect or whether it will be compensated as well. And that's an interesting question. Of course, if you have a brain that is imbalanced to start with, I think that's how we know more in terms of clinical studies, then in a way, at least in theory, it may be safer. But there is also a potential concern that you may still also induce an imbalance, another type of imbalance in another area, but at least you have a benefit. That's also why it's a bit complicated thinking and cognitive enhancement, is that if you start doing that and you do that for longer duration, several sessions, and you really train in a specific cognitive task, is that going to affect other areas of your brain? And especially if the benefit is questionable in terms of healthy subjects.
Great. So we've talked a lot about some of the quantitative effects of this subjectively. Well, first of all, I guess, have you tried this yourself? Have you been a subject of tDCS as well as applying it to others?
Sure. We tested, and I wanted to test it in myself as well. So I tested it myself. I wanted to see the sensation. I haven't done for more than one session. I've done one session to see the effects of tDCS in training sessions, but I couldn't see it. And that's one thing that also in our studies in healthy subjects, they do say that they don't feel any changes, at least that they could perceive. But even though we still get changes in reaction time, changes in performance in a computer-based task. And that's why also it depends on secondary training, and likely it's difficult to perceive as well. So
right. Yeah, I mean that's sort of, it seems like a continuing theme with some of the things that we talk about on this podcast, because there's a lot of things that can sort of statistically on these broad-based studies, they're shown to have some cognitive benefits, but you don't necessarily feel a subjective effect from it as a single person anecdotal user. And it's kind of my sense that probably if you can feel something working, that's it almost means that pendulum has swung a little bit too far.
Yes, exactly. No, I think that's a very good point, and that's what I tell my patients. Now, I remember when I was I'm doing research 100% of my time, but usually that's my patients that I used to see. That's something that I used to say, is that whatever treatment you're doing in terms of inducing changes, learning again, patients after they have strokes, you're not going to see the changes because this is low. It requires some changes in the connectivity of your brain, and usually you don't perceive that. But it's true, if you do something that induces drastic changes, so likely that may be associated with adverse effects, or the effects may be temporary, because you don't have any treatment that can induce these drastic effects and will be long lasting. Otherwise, the brain cannot change at that pace.
Yeah.
So that's a very important concept.
Well, I mean, the ability of any organism to reestablish its own baselines, and for that baseline to start to feel normal again, it's like, that's kind of one of the most amazing things about biology.
Yes, exactly. And then when usually they don't perceive it as well, the changes.
Yeah. Well, thank you very, very much. Is there anything else that you feel like we skipped over, or that you'd like to circle back to that maybe we didn't touch on? Any questions I should have asked that I just didn't know enough to?
No, I think we could cover the main aspects. Perhaps a final comment in terms of the future of brain stimulation. I think it's we're still at the very beginning of the development of non-invasive brain stimulation. We did show some clinical effects and beneficial effects, but I think for the future, we need first to find the optimal parameters for each condition. Whatever condition is being studied, it's different different compared to other diseases, and the parameters are different. The way that's used is different. And second, a better system would be a system in which we get information for the system, for instance, a brain excitability, and you use that information in order to adapt and change the parameters of stimulation. So I think these smart systems, they are going to be much better and will induce much better effects because the brain is a dynamic.
Right. Something that's like a combination of tDCS and a real-time MRI. So it's sort of...
Exactly. Real-time MRI, real-time EEG, because it's a very different, and that's an interesting thing because the concept, for instance, if you're thinking on developing something to treat your heart, you want something that is very constant. Of course, it may adapt to your level of physical activity, but it's always the same. The heart sort of pumps the blood in the same way. But then the brain stimulation is different. The system is dynamic, is changing, and then sometimes you may want to increase or decrease activity, you may want to change their stimulation. So the best system would be a system that will take into account this level of changes, and it is fast changes as well. So I think in terms of the future, so that's what's needed, and there's a real chance to develop better treatments with brain stimulation in general, taking into account this concept.
Alrighty, well, thank you very, very much. The listeners, I'm sure, are going to really appreciate this and get a lot out of this episode, and I really just appreciate the time.
Thank you so much for having me.
So thank you very much to Dr. Fregni for sharing his time and expertise on transcranial direct current stimulation with us. I kind of wish I'd asked earlier in the interview whether he'd actually ever tried it himself, and I was very glad that he had at least once. Personally, if I was a would-be mad scientist type and had access to a whole lab full of cool equipment, and I'm sure he does, I probably would have tried it more than once, and maybe he has, and he's just not telling us. But this is all speculation. He sounded like a very upstanding and respectable scientist, so I'm sure he's behaving absolutely properly there. Let's move on to the ruthless listener retention gimmick.
Smart Drug Smarts, ruthless listener retention gimmick.
And the subject of this week's ruthless listener retention gimmick is fan death. Have you heard of fan death? I had not heard of fan death until recently, but apparently this term has been around since at least the 1970s, so it predates even me. What fan death is? No, it's not like if you're a rock star and you have some crazy psycho fan that tries to kill you. Fan death is the widely held belief in South Korea that if you go to sleep in a room with an electric fan running, you will die. Yes, you will die. This is something people believe. South Korea, this is not like a place where people can't read and write and stuff like this. This is a highly educated, for all intents and purposes, first world nation. They make Samsung televisions. There's probably the Korean kid in your math class that got better grades in math than you did. I mean, these are smart people. How is it that this nation believes that sleeping in bedrooms with electric fans running will cause their untimely demise? And yet they do. The origins of the belief apparently trace back to a government-perpetrated conspiracy in the 1970s when they were trying to convince people to cut down on wasting electricity and sort of trick people into believing that if they kept their electrical things running at night, death would befall them. So I don't know. That seems weird too, but that's where people think that this ridiculous misconception came from. The proposed causes are related to hypothermia and asphyxiation, both of which, I just don't need to tell you how preposterous this idea is. I guess I wanted to sort of shine a flashlight on this, just to get each of us to think about, what in our own sort of mental models of the world is akin to fan death. What do you believe that to an outside skeptical observer would look just completely preposterous? Like, can you look at your own worldview and sort of tease apart anything that you think that is as stupid as fan death? I've certainly been thinking about that. Anyway, so a little bit off topic for Smart Drug Smarts, but I did want to let you know about this, and I'll put a link to the Wikipedia page. Speaking of which, Wikipedia, I was at Wikipedia, and I could not help but notice that they're doing a fundraising drive right now looking for donations. They're a nonprofit. I use them all the time. You probably use them all the time, too. I don't really know anybody that doesn't hit Wikipedia several times a week, and I don't know. I gave them $10. I think we probably all should. It seems like a very worthy use of your $10. Anyway, I'm just putting that out there, a little bit of a 'tis the season recommendation.
You've been listening to the Smart Drug Smarts podcast. Visit us online at www.smartdrugsmarts.com and subscribe to our mailing list to keep your neurons buzzing with the latest in brain optimization.